barcode facility in your phone. You can just scan it. As we are showing, as we are progressing with the webinar, we will change that questions. We will tell you when we are changing it. Once you press this code, enter this code and submit, you will see the questions. If you want to go to the next question, you need to submit that. As you will see right now in your browser, this will be the first question, my geographical location, which continent I am from. As you see that question, the next question will pop up. Once you submit, what do you do? Are you an ophthalmologist, pediatric ophthalmologist trained, or an adult ophthalmologist who does pediatric cases? You are an optometrist, ophthalmic technician or administrator, or other audience for this meeting. So you will see these two questions coming because there'll be a little bit of lag. So please go ahead and answer. And it's a pleasure to introduce Dominique, who is born in Paris, France. She's a professor of ophthalmology and head of the department of Necker University Hospital for Sick Children in Paris, and also of Tara Rare Eye Disease Center. He's the head of orthoptic department at Paris University and associate researcher at INSERM unit. She is also on the executive bureau of WSPOS. It's great to have you, Dominique, today. Again, the next panelist and my co-moderator, Ken Nischal. Everybody knows in the field of pediatric ophthalmology and the whole field of ophthalmology. He is born in Nairobi, Kenya, and he grew up in Slough, England. And he is by heart is a Khattar Punjabi, as you all know. Currently, he is in USA, Pittsburgh. He is a professor of ophthalmology at the University Medical School of Pittsburgh. And he is also a division chief of pediatric ophthalmology and strabismus at UPMC Children's Hospital, Pittsburgh. He takes care as a medical director of digital health, UPMC Children's. As well, he is a vice chair of quality of UPMC Eye Center. Thank you so much, Ken, for leading this whole society, and we can do much more together. And it's also a pleasure to introduce my dear friend, Connie Lai from Hong Kong. She is a fellow of College of Ophthalmologists of Hong Kong. She is also an associate consultant at Hong Kong West Cluster Hospital Authority. She is a subspecialty coordinator for pediatric ophthalmology and strabismus service. She is also an honorary clinical assistant professor at University of Hong Kong. Over to you, Ken, before Connie starts her first talk.
Thank you so much. I think you'll all agree we have an amazing panel. And the really amazing thing about this panel, really quite amazing, is that we've all known each other for a long time. And we're more like friends. But I want to ask you now some Menti questions. Now, I know some of you are reluctant to use Menti, but I think it's really important. We need you to learn how to use Menti.com, because on August the 1st, 2020, when we do a Global Challenges quiz, the use of Menti will be absolutely crucial. And you all will be, well, you'll have an opportunity to be part of history. We'll give you more information in the coming weeks, but you will have an opportunity to be part of history. So question number 3 is, what type of teleophthalmology have you participated in? Synchronous, asynchronous, not sure. Question number 4, have you participated in more than 5 live teleophthalmology patient visits before the COVID crisis? Yes or no? And question number 5, have you participated in more than 10 live teleophthalmology patient visits in the peri-COVID-19 period? Yes or no? Okay, Connie, you're up.
Okay. So I would like to start my talk on the Hong Kong response to COVID-19. To be honest, we didn't have any lockdowns at all. So I guess it will give you a highlight on what's going on in my side of the world. So the first difference to our response is that we've been through this before. In 2003, we had the SARS crisis, and then we had outbreaks of bird flu and swine flu. So for most of us, wearing a face mask is a no-brainer. And most of the people in Hong Kong were already wearing face masks before the government had any formal announcement that we had to. So given our proximity, Hong Kong adopted a track and trace approach and closed the majority of our borders, leaving only a few open so we can monitor the arrivals. And since SARS, the Hong Kong SAR government formulated the Center of Health Protection, and they made a preparedness and response plan. And this is a 3-tier system: alert, serious, and emergency. I'll have to say right now we still have alert for MERS, Zika, and Ebola virus, but right now in Hong Kong we're working under emergency because of COVID. And that means that nearly all branches of the government is involved: the chief executive, housing, finance, education, so everyone is on board. So this is a chart from the University of Hong Kong that highlights the responses that we made regarding to travel, case-based measures, and community measures. So I'll highlight that Hong Kong had the emergency level announced at the 26th of January. And from February 9th, we already started to close the borders with mainland China. February 16th, the public hospitals began to adjust non-emergency services at the hospitals. From March 19 onwards, we imposed a 2-week mandatory quarantine for all arrivals. But as you can see from this graph, because a lot of people wanted to come back before the quarantine, we had a spike of COVID cases. About 70% were all imported cases. And so from onwards, April 4th onwards, all arrivals at Hong Kong Airport will be tested for COVID-19. So those that needed to go into quarantine, how we monitor them is that at the airport, they'll be given a hand bracelet, and then they had to download an app on their smartphone, and the government will need them to check in to see they've been obedient. So what else we can look at is a latest situation webpage that anyone can access from the world. And it gives us in real time how many cases that we have in Hong Kong. And so far we haven't changed. We had no new cases today. And it will highlight geographically where positive cases of COVID were found in the whole territory. And you can actually zoom this map, and it would highlight the map down to the street and down to the building which the case lives. So the district can actually boost their infection control measures. No personal info is on this webpage, so there won't be any privacy issues. So the healthcare system in Hong Kong, 80% of it is in the public system, while 20% is in the private system. Hong Kong is divided geographically with a major hospital and satellite centers. And in our unit in the Hong Kong West cluster, patients will have to wear a face mask, and they have to have a temperature check, and we ask a very simple travel history at the door. We actually space out all the arrivals so we don't crowd the building. And patients can only have one person to accompany them. And because Hong Kong has the emergency response, everyone needs to wear a face mask. In our operating theaters, it's single seating, single directional with separation. And some units, eye units in Hong Kong also have social distancing in their wait rooms, and also some air purifiers in their unit as well. So patients that can defer their appointments are encouraged to do so, but they can come and have their medications to be refilled. And because 80% of our population is in the public healthcare system, we have a clinical management system which is territory-wide in every public hospital. And so any patient that comes in registered with their Hong Kong ID, we linked up the system with the immigration department, so we can actually see whether the patient has returned to Hong Kong 14 days prior to their follow-up. So we see that there's a positive travel history, or people that have successfully finish their quarantine, or unknown. But this only pertains to a Hong Kong registered travel document. So far we can't see this information if a patient has traveled with a foreign passport. According to our guidelines issued by the Center of Health Protection, and because now that we're in the emergency response level, PPEs for staff and for the hospital and clinic areas is very, very clear cut. So right now our eye unit is considered other patient areas. So all we really need to wear is a surgical mask and have standard precautions. But if we see cases that are highly suspicious, or if we need to go to the dirty wards or COVID wards, then of course we will have to don protective gear and N95 as stipulated in the guidelines published by the government. So in our eye unit, all slit lamps have a shield, and we wipe down our instruments after every use. And for myself, I like to be in my scrubs. I wear a cap, a visor, and a face mask, which is mandatory for everybody, even kids and adults. And so children above the age of 3 need to wear a face mask. This is a short graph highlighting the pediatric eye units in Hong Kong, because I asked my colleagues whether their center had any differences. We did not need to cut our patient quotas at all because we didn't have any quarantine, but we saw a large default rate over 50%. We're pretty Spartan. We don't have toys in our consultation area ever. Kids usually bring their homework to do. Because we were pretty well prepared because of our SARS experience, we didn't need to put a shield in front of our indirects. We didn't need to put a shield in front of our portable slit lamps or directs. ROP practice hasn't changed. Our treatment hasn't changed. We stopped all our elective surgeries, but we can still do emergency surgeries. Some units in Hong Kong actually had a deployment roster in case we needed to help out with high-risk areas. Only one cluster had to send staff to help up in the medical ward because they had an outbreak of COVID cases in their geographical area. I'd like to take this time to actually highlight the problems that the private sector has been facing. Even though they see 20% of our population, they saw a large drop of their attendances as well. Some of them had to close clinics. Some of them had to ask their staff to take no pay leave. And on top of that, getting PPE is pretty well on their own. They had to resort to their own contacts, their own ways of getting protection for themselves. So this is an article published in February of this year from one of our eye units highlighting the control measures in an ophthalmology clinic. So I do encourage you to go online and search and have a look. And aside from other measures we used, we have UV sanitizers available in the hospital to sanitize iPhones and iPads for our staff. In the eating areas, it's single-facing, unidirectional separation. And for staff that are worried about going home and transmitting the viruses to their family members, we've actually liaised with a few hotels near the area, which they can give subsidies and arrange places for them to stay. And of course, if they needed more support, we have hotlines for staff psychological support as well. So I'd like to acknowledge the following doctors that gave me a little bit of an outlook and idea of what they're doing in their eye clinics. And especially I'd like to give a shout out for Jane, who I asked about what was going on in private practice. So coming these few weeks, Hong Kong is going to slowly open up our service because we haven't had any positive cases. So we're gradually going to phase back our elective surgeries. Attendance in the clinics are gradually going to increase, but still try to keep the social distancing. And we'll just have to keep it slow, be very, very flexible, and just be aware of what we're doing. So thank you very much for inviting me for the talk.
Thank you so much, Connie, for the very crisp talk and your experience. I'm sure people will have more questions. You can type in your questions on the Blueberry link and YouTube, wherever it is. Now I request Dominic to speak.
Ramesh, just before you start, I just want to let everyone know I'm getting notices from all over the world. People are listening from Turkey, Indonesia, India, South America, Peru, Oman, USA, Russia, Brazil, Iran, Singapore, Lebanon, Israel, Argentina, USA, as I said, Philippines, Turkey, Denmark, France, Germany, Italy. We truly are one world.
Thank
That's
you.
great.
I request Dominique to share her experience with regards to seeing patients in the OPD as well as operating room during COVID lockdown. Dominique, over to you.
Thanks for listening and for giving me the opportunity for explaining what is going on in France, because I think every country is a little bit different and we adapt in a different direction. So So just the first question, do you think conjunctivitis can be the primary sign of COVID-19 disease? I mean, you think it could be only a conjunctivitis, and that this is a real question, and that will explain why telemedicine could be very useful, and why we must be careful also. And so the answer is yes. And there is 38 references with ocular symptoms and ocular tropism of SARS-CoV-2. And we had the presentation, the first presentation of COVID-19. And there is some publication that are just ongoing, and I'm sure we will find out for more of these. So it could be really the interest to understand that just a conjunctivitis could be a very big problem. And our case was a patient that has just a conjunctivitis on the morning, and on the evening he was just indoor patient because he had a severe respiratory disease. So it's very tricky. So what are we doing for the consultation during COVID-19 lockdown? Because we were locked down from 17th of March until 11th of May, which is a very long time. And when I think we didn't learn about any. When I see the slides of Connie, we should be aware of it, and we were not. And so the 17th of March, I say, okay, everybody at home, except doctors, of course, except physicians, for emergency. So they were supposed to have only ocular emergencies. Patients needs an authorization signed every day, even for doctors, to say where you were going. And of course, you were supposed, for instance, if you go outside, you can go for just doing some running, but it should be within 1 kilometer around your house. And for authorization, you could have an authorization for going to see a physician in emergency, or for something which were important as family needs, for instance. At this time, there was no mask required for patients at the beginning. And even more, protection for doctors were really late, I suppose quite too late. And there was mask, doctor's blouse, protective glasses, so that we have done that on March. But it was not everywhere at the same time. We had also protection for our slit lamp, shield protection. We have, of course, hydroalcoholic gel barrier measures. And we added progressively national guidelines. And you can see on the slide that there is regular mask, FFP1, but we have also FFP2 for the surgical room. And there were some very, very sparse tissue mask. So you can see here, it's still ongoing, of course. So there is a double shield here, of course, a blouse, but I don't wear a cap, but you can wear it if you want it. And you see, it was done also by the hospital. It was just, made by. It's still ongoing, of course. We have also some masks for children, and you see that's for adults, and there was for children, and we give that for children at the entrance of the hospital, just to see the nature is nice. This is in my hospital, in the garden, so we have ducks and small ducks, so life is going on. We have also guidelines that we have been done by the National Ophthalmology French College and the society. And so you can see here, I'm sorry because it's in French, but you can see patients, for secretary, for the where the patients are just staying, for the ophthalmologist, but also for the orthoptist, and for the units of consultation, and what are the risk factors, how to deal with the mask, and how we can go further for the activity. There was this National Ophthalmology French College, so you can see here about what can be done for emergency, like acute strabismus, nystagmus recently, recent strabismus, visual impairment also, new visual impairment, local chorea, of course, ophthalmal steering, not lacrimal obstruction, red eye, infection, traumatism. Just one thing is, we were very astonished, that there is less local chorea and ophthalmos. So I don't understand that it could be less, it is impossible that there is less cataracts, congenital cataracts or congenital glaucoma. So we will see how it will be going on. There was semi-emergency also with amblyopia with risk and follow-up of organic disease as congenital cataract for sure. And that can be postponed with amblyopia, refraction, strabismus control, and visual screening. So I think that the big problem was surgery. We had a theater, operating theater, and there was 6 operating rooms, and they were transformed for intensive care units for COVID. But at least they changed their mind, but they just took the respiratory systems and, also for syringe, they were sent to other care units in area in France and also in trains. And so we were obliged to share with another operating theater. And we have only emergencies, classical congenital cataract, congenital glaucoma, ocular ones, of course. And we have for the patients nasopharyngeal sampling the day before, or to be sure to have a result before. And now it's just going back a little bit with semi-emergency. It is, of course, very difficult to choose what case is appropriate or not. And one point is, I think patients are quite scared to come back to the hospital. And the next step for us is to just recover our operating rooms, probably in September, coming back to and we hope it will be okay this one. This is the last dashboard for France and Europe, and we hope to back soon to normal functioning. However, we don't know when exactly. And in France, we have 180,000 confirmed case and probably around 300 deaths. So I hope it will be back again in less time, and hope it will be back every country again. Thank you very much.
Thank you, Dominique. I think we have time for a few questions. I will start with one question for Connie. You said for the routine patients, you just use the mask and the gloves for the examining the patients. And for the patients, you ask them to wear mask. Is it true, or do you have any other personal protection equipments?
Well, for our unit, what we really just needed to do was hand hygiene. There are a lot of alcohols, dispensers, and a mask. That's all we really needed to use. We were very flexible. Some staff were thinking that this person was going to be very high risk, or they were in doubt. We actually have a small room right next to the front door that could be an isolation slit lamp room, so they can do their examinations there. But most of our patients, we're kind of thinking that they're quite clean, because we have so many checks and balances already in place that they can just wear a surgical mask and come up. And that's it. That's all we really needed to do.
What's your OPD numbers compared to before? Are you seeing 50 or 70, or at what percentage you are in right now?
Oh, we're in January or so, say in the morning, we see about 20 kids. We're supposed to see 20 kids in the morning. During the high time from January, February, where everything was uncertain, the numbers fell down to just 5 people showing up. And then now, because the situation is better, they're slowly creeping back up. So I think right now we're still seeing about from 20 patients booked. We're probably seeing about 11 to 12 right now in the morning. So it's not too bad.
So can I ask a question? And it's for all the panelists. You know, there are some people listening at the moment who don't have access to the kind of surgical masks, N95s that we've been talking about. What do they do? What can they do? You know, it must, you know, we're talking about PPEs like they're easily available, but there are parts of the world where they're not available. And I suppose this comes to the question is when you have an ordinary procedural mask or a surgical mask, what is it doing? Max, I know you have some figures about the size of the viral particle. We were talking about this yesterday.
Yeah.
You want to discuss that?
Yeah. I mean, we know that the virus is about 0.10 micron, and an N95 mask, I mean, a filter for 0.30 micron. So they should be ineffective, but we know that they are effective because of droplets, actually. Well, if they don't have any kind of mask, because I mean they can't. I think that tissue mask, homemade mask, could be. I mean, it's better than nothing, because here in Italy, a lot of people are creating masks by themselves, a kind of homemade with tissue, any kind of tissue. That's what I suggest. That's what we are doing here.
So what you're suggesting is, and I've seen this, I have talked to people from around the world where PPE is not available. They make a cloth mask, and in the cloth, they put either a coffee filter or a double tissue. Now, the problem is with tissue, it becomes moist quickly. Even the coffee filter will become moist, but it takes longer. So if you don't have PPE, you make a cloth mask, and in the actual face part, what you want to do is put a coffee filter. Obviously, if you can get your hands on proper PPE, that is the best. But we have to do something to protect ourselves, our loved ones. And that brings me to another point. How many people on the panel are using UV light? What is your thought about UV light?
I do not use UV light, but I use a double. You see on the screen there was a tissue mask and there was filter inside, and it was double. So I just recommended that in March to all my staff and to the patients when they come back. But UV light, we don't use it at the time.
Connie, any role of UV light since you've been through this before?
I don't personally use UV lights, but like hospitals set up a few stations for the iPhones. Actually, what I do with my iPhone is that I have a Ziploc bag, and before I go to work, I put my phone in a Ziploc bag and I use alcohol and just wipe down the Ziploc bag every day. Some people have bought their own UV sterilizers. I haven't, so I think it's still a mixed outlook on UV light right now.
But is there any evidence that UV light does enough? Is there any evidence? I mean, is there any, unequivocal evidence? I'm not sure I've read that. Has anyone read that?
Not sure myself.
I didn't see any.
There is no evidence on coronavirus. There is no evidence on coronavirus.
And what about, Connie, you were talking about the OR, even you, Dominique. What precautions do you take when you go to the OR? I mean, do you think that the only aerosolizing procedure that we do is nasolacrimal duct obstruction clearance? I mean, do you think that there are other aerosolizing procedures?
I think you're right. We try to have a special mask, FFP2, and to be sure also the patient is not COVID positive, and that's why we do the sampling. And also we keep out of the staff at a minimum distance, which is not usual. So we try to do that and to be aware of the surface that we put our staff. And I have also like a Ziploc to put my stuff, and I change it. That's right.
So over in Hong Kong, for the operations, we've actually stopped doing probing and syringing and any nasolacrimal duct operations. But we still have phaco going on, phacoemulsifications for adult cases. And so the only change in practice is that we actually have the patient wear a surgical mask. when they're on the operating table, and we use a bit of micropore and just, seal it off. And then of course we drape on top, and then we do our phacos. And so that's the only difference that we did in procedure. The waiting rooms, we only allow one person to accompany the patient, and do social distancing. And of course the history and the temperature taking, we still do that, but we haven't asked for any serology or any tests for COVID for any of our patients. We don't swab them, say, like ahead of time.
So how many? Sorry, go ahead.
You had regular cataracts or just congenital cataracts? Because in France, regular cataracts were not recommended because it was not emergency.
Pediatric cataracts in emergency, we can actually arrange. Because in Hong Kong, we never really had a lockdown. So we actually reduced our capacity to do cataracts. We maybe have about 10 sessions, and then we just cut it down to maybe 2 sessions. And during this time, we also had the operating theater was having an overhaul. They were changing all the filters anyway. So it just ended up being a very good time to do that. So we didn't really stop our adult cataract sessions at all. So it's just reduced a little bit of the volume for just to keep the crowds down.
So I have to retract what I said. David Granite has just texted me. There is a research article just published in Virology. Far UVC light efficiently and safely inactivates airborne human coronaviruses. So hot off the press. This is in Virology. The lead author is Manuela Buonanno, and the senior author is David Brenner. I haven't read it. I suggest that if you're interested in the germicidal effects of ultraviolet light, typically they're saying at 254 nanometers, please read that. It's in Virology. It may be very helpful. So David, thank you very much for sending that to us. That's the beauty of the connectivity of the world right now, right? Together, apart. Okay, so I think we'll come back to that. There's some questions coming about how we give confidence to the people we work with and our patients as we ramp back up. Connie, it sounds like you guys were ready to keep going, but there was a lack of confidence in the public, if you like, about what was going on. And we'll talk about that later. Right now, what I'd like to do, for the sake of time, is I'd like to invite Nicola to give her presentation about events in Cape Town, South Africa. So while Nicola's getting her slides together, have we got them? Okay, fantastic. I was fortunate enough to visit Nicola. Here we are, Nicola. Can we can't hear you at the moment. Can you unmute? So I was fortunate enough to visit Nicola last year, and her place of work is just beautiful. Where she works, and from her ORs, you can see the tabletop mountain, and I'm interested to hear what she has to say.
Can you hear me? Can you hear me now? Can you hear? Great, thank you. Can you hear me? Good. Okay. So good morning, good afternoon, and good evening. I'll be sharing what we're currently experiencing in Cape Town, South Africa. South Africa had its first COVID cases, very first COVID case on the 5th of March. We then had a very strict lockdown, which was declared on the 27th of March, despite only having one death at that stage. The effect of the lockdown on the spread and the magnitude of cases was extremely successful. However, it has come at a huge economic cost to this third world country. After 8 weeks of lockdown, we now have approximately 20,000 confirmed cases, 397 deaths in a population of 59 million. It's important to note that in South Africa, of that approximately 60 million people, 9 million people are on private health care and 50 million depend on state medical care. This logarithmic graph shows the unique epidemic curve in South Africa. We had an initial rapid increase in transmission due to the introduction of foreign travelers, followed by a sudden decrease because of the early and very strict lockdown. This initial bump has been followed by a steady rise in daily numbers due to community transmission. The initial predictions were for our epidemic to peak in April. However, the latest predictions are for the peak to be in July, August. Only in the past week have we seen regional intensive care beds filling up with COVID cases. The greatest benefit of the early and extended lockdown in our country has been that we have had time to prepare. South Africa has had time to acquire personal protection equipment from a constrained international market. We've had time to commission additional hospitals and ICU beds. We've had time to acquire and develop ventilators. And we have trained and mobilized 27,000 community healthcare workers. Now, this has only been possible because of the healthcare workers, these healthcare workers previously being used to fight against TB and HIV, and they were redeployed. All government-employed doctors, including myself, are expected to make themselves available for the upcoming surge, potentially outside of their field of expertise. Yes, we have had time to prepare and acquire, but we are certainly still hampered by shortages. We are expected to reuse and dry our N95 masks in a paper bag. These masks and other PPE are only to be worn in high-risk interactions to save on stock. In the clinic or in our consultations, we are encouraged to not use N95 masks, and we use surgical masks. The clerk and anyone else in the clinic are using cloth masks. I work in a 300-bed university teaching pediatric hospital, and we served predominantly the uninsured population. We have 11 theatres, but currently only 4 theatres are operational, provided the staff are not quarantined or sick. 2 of these theatres have been dedicated as COVID-only theatres. In our paediatric hospital since the 26th of March, we have been instructed to postpone all elective surgery for 3 months, and all routine clinic appointments had to be postponed for 4 months. Only emergencies are to be seen. Therefore, early detection, any follow-ups and any screenings have all been impacted by COVID. Calling patients to reschedule has been disastrous and most frustrating. The sad truth is that the economic effect of lockdown has led to patients perhaps cancelling their cell phone contracts, and we are unable to communicate with a large number of our patients. Have we made any changes to ROP screening protocols during COVID? We have most definitely erred towards 3-week reviews wherever possible in the attempt to reduce the numbers and promote social distancing. Once neonates are discharged home, and the attendance at the ROP screening clinic has been exceptionally poor. Many mothers rely on public transport, which has been most problematic during lockdown. Also, financial issues and fear of COVID and officials requesting travel permits have been the main barriers to good follow-up. Any neonate who has no ROP by 35 weeks and has vessels past zone 2 and who is on room air is being discharged. again to try and keep the numbers down. What do we know about COVID-19 in neonates? The initial data reported in neonates so far have been quite reassuring. There are a limited number of reported cases, and the extent and clinical significance of vertical transmission is still unclear. Transmission of COVID-19 to neonates is thought to occur primarily through respiratory droplets during the postnatal period of from the caregivers. So the infection risk of medical personnel working with infected neonates is still unclear. So our approach is to wear an N95 mask and gloves during ROP screening. And for known COVID positive neonates, which we've not had to date, we do plan to wear full PPE. During lockdown, there has been no teaching of residents or fellows, so the practical skills of ROP screening are not being acquired currently by our teaching of students in training. But when we have teaching cases, these are shared using RedCam images. Here is a graph of new COVID cases per day normalized by country population. Italy and South Africa have similar population sizes at approximately 60 million people. You can see that South Africa's logarithmic curve, the one in black, is certainly less steep than Italy's curve, which is blue. But at this relatively early stage of our epidemic, we are fearfully awaiting what trajectory we will follow. South Africa has the largest HIV epidemic in the world, with 7.7 million people living with HIV, compounded with a huge burden of tuberculosis. The risk of COVID-19 in those living with HIV is currently unknown. Only in the next few weeks and months will this become more clear. In early March, we rescheduled many patients for June and August. With the new predicted peak, and with our hospital filling with pediatric cases transferred from other adult and secondary services to free up beds in those hospitals, we will need to reschedule many appointments. We certainly cannot say that we are coping, because our storm has only just arrived. Thank you.
Thank you, Nicola, so much. I'm going to pivot now immediately to Max. Max, you were in the epicenter, the European epicenter. There were days where I would wake up in the morning and pray for you and Paolo and all my friends in Milan. Max, tell us how it's been.
Yes, thank you, Ken. Yes, and that's true. We were we wake up in the morning and we were in the epicenter in Europe. We're the first country in Europe to be affected by a pandemic. So we were really scared about that. So first, thank you, Ken, David, Ramesh, and WSPOS to give me the opportunity to talk about this. I split my presentation. The first part that means just the facts, what happened actually. And we will talk about living. We will talk about feelings during the discussion, because feelings are difficult to write unless you are a novel writer, that I'm not actually. So I wanna talk about facts now, and I wanna talk about feeling and perception during discussion. So living, working, and COVID was a really forced coexistence. In the middle of March, I wrote an article on San Diego Tribune, thanks to David Granite and Ken, about what happened in Italy. Because, in that period, we were really scared about that. And we had the perception that we didn't learn anything about history, because what it's happening now actually happened many times years ago. But it looks like that we don't care about happening history. So we had the phase one during the pandemic. That was at the beginning, when we were in the middle of the pandemic. That is finished actually. And so if we talk about emergency outpatient surgery, we say that during this phase one emergency area was available, of course, but magically looked like few patients needed a pediatric ophthalmologist. And we don't know why. Maybe fair to go to the hospital, even if necessary visits, or sorry. Okay. Or fear to go to the hospital, and previously many unnecessary requests of pediatric ophthalmology. Sometimes it happens. And during phase 1, also about outpatients, totally canceled. And about surgery, totally canceled except for emergency. And what about leaving? As I told you before, we'll talk about leaving during discussion, but it's interesting to know that if you look at what happened in 1918, this is Milan, this is Italian, of course, but this is what happened in Italy is 1918, and what the government told to Italians. What is written here, that in 1918, they told us to wash their hands, to not go to the train, to keep distance, to wear masks. So we are talking about 100 years ago, and during the Spanish flu, and looks like nothing changed. Same, the government say to do the same stuff that actually are asking to do now. During the phase 2, just started 2 weeks ago, we still do not know for how long. And if we see again emergency area, outpatients and surgery, emergency area is always available, but still few patients. Reasons maybe are the same of phase 1. And about outpatients, actually something changed, because we have just started to see patients, but few patients can be seen to avoid gatherings, especially in registration area that in our hospital are common with other specialties. And 2 days before the visits, patients receive a call with an interview about their condition. These things change between institution and town. And only one parent is allowed to enter in the hospital. All patients and parents must wear masks, surgical mask or homemade mask, as we told before. And if they don't have one, the hospital gives them the mask. Visits are scheduled every 30 minutes. It depends on the hospital, of course. Doctors and nurses must wear masks and gloves, and they have to disinfect areas touched during the visits. Unfortunately, rarely shields for slit lamp or others are available. Surgical mask or FFP2, that's what we have. And about surgery, during phase 2, emergency, of course, available. Elective patients that for any reasons can't wait anymore, because what is not considered as an emergency 3 months ago, maybe it becomes an emergency after 3 months. 2 days before surgery, patients and one parent, because one parent is allowed to enter in the hospital, are tested via buffer, and they remain in the hospital until the surgery. And leaving, well, again, we'll talk about this later, about living in the phase 2. What about telehealth? Well, there is no official telehealth here, and every doctor decides how to manage it. So let me thank all town that during our phase 1 showed their feeling toward my country. You see from Canada, United States, and Poland, Germany, Bosnia, Emirates, Israel, Albania, Cuba, and China, because they sent us doctors and nurses to help us, because we were actually overpowered from the infection. So all these countries sent us all doctors and nurses to help us. And let's thank also to the moon. And let me thank also the sick wards. And let me thank doctors and nurses that hug Italy during that time, and help people survive, and especially to 160 doctors and 40 nurses that died during the pandemic so far. Just help us. Thank you.
Wow. Wow. Ramesh?
Yeah. As the discussion begins, I have one more Menti question here. You can see the question on the screen. You can answer. In the meantime, if there are any questions, we can go ahead and...
So while Ramesh puts the Menti question up there, I want to say that there are lots of questions coming in. We are going to try and address them, but there are two things specifically that I want to try and address with the panelists. You know, one of the things about COVID has been uncertainty, and I want to know what your coping mechanisms have been to deal with the uncertainty and how you have coped during this period of time. Let's kick off with Connie on that one.
Well, I was a resident during the SARS time in 2003, and comparatively, I think I was a lot more uncertain back then than I was now. Because when SARS hit Hong Kong, it was a lot closer to home because it started in Guangzhou. We didn't have WhatsApp, Facebook, you know, it's just a regular phone, no smartphone. So the information wasn't spreading as widely and easily as it is now. As a resident, I was deployed to other areas. And so you were very uncertain because you didn't have the information. The hospital I worked off was getting swamped. I had colleagues dying, doctors and nurses, because it was very virulent. So being through this before and then having COVID now, I don't know whether I'm older or wiser. I think I'm a bit more calm, or at least a lot more balanced, because it's almost like the second time around. And it seems that we're a lot more prepared now because, you know, the government came up with this response system. So we had these guidelines in place, and that the government and everybody was saying the same things. You're not getting different, you know, grumblings from different places. So in a way, personally, I thought that this time around, even though it's not good, the coping was a little bit easier for me.
Nicola? Sorry. Oh, Dominique, go ahead. Then we'll go to Nicola.
Yes, thank you. I think really, Max, we had quite the same thing in France, and we were supposed to have 3 weeks later from you, and we were supposed also to learn. And I think we had all the information, but the information was so diluted. So I think we were not, the adaptation was not so easy, and we were in the same problems as in Italy, probably more in Italy because you have older people in the country, but we had a big problem also, and we don't know exactly how many doctors, physicians and nurses just really died because they don't tell it probably.
Ramesh, what about you? What's been your coping mechanism?
In India, I think personally, as well as the institute point of view, I will speak. We had lockdown pretty early. We are almost more than 60 days lockdown now. So initially, I think the first week it was difficult. But in terms of patient care, we were planning, we were tapering very slowly, seeing less patients. So we had some kind of what we have. We didn't know which phase we are going, whether we have a community transmission or whatever it is. Before we locked down, we did not have community transmission. Whatever patients came from abroad, we had that situation. So we were continuing till the last day, and then we had a lot of time to think. Now 60 or 65 days, most of the systems are in place because of early lockdown. We could prepare better. Otherwise, India is a huge country. It could have gone in any other direction. So both personally as well as from patient's point of view, I think we are well prepared.
Nicola?
I can say the same. In the beginning, in early March and before we locked down, there was a lot of nervousness and tension amongst the medical profession because we weren't prepared and we didn't have protective equipment. So it was nerve-wracking, and you could sense that a lot of colleagues were not doing well, literally sleepless nights. But that has settled down because there are systems in place, protocols in place, guidelines, and we now have personal protection if need be. So we're waiting and ready. So it's that type of environment now where people are ready if we know that we have to have a peak. We can't be more prepared than we are. there is definitely a serious amount of what is referred to as lockdown fatigue that we're experiencing in non-medical people, and yeah, but pretty much the same as Ramesh. We feel prepared.
The definition of the word third is.
All right, Max, tell me about how you coped.
Yes, thank you, Ken. Well, as you know, I asked you about 3 minutes to answer these questions because, as I told you before, we were overpowered by this infection. We were unprepared. I don't know we were unprepared. I really don't know. Just because maybe we thought that China is far, and this is stupid because we know that the world is not so far. I mean, maybe 100 years ago, if the infection was in China, maybe it took about 1 year, 1 year and a half to come in Europe. But now with this short connection, in one day, the infection can come everywhere in the world. So I don't know, we were unprepared. And I saw that also other countries were unprepared because they didn't see what happened actually in Italy. So, but what I want to say that because we were overpowered, we also all ophthalmologists, especially in my area, that was Lombardy, we were asked to go to the intensive care unit to help anesthesiologists. That was really, hard for us because we are really unprepared to do that. And in other hospital, ophthalmologists were asked to go to the general emergency area to let doctors go to the intensive care unit. And I was there. I was in intensive care unit for a while, actually for a short time. And there are patients that usually we don't know that kind of patients because we are ophthalmologists. So it's impossible to forget the scared look of their patients. It's really something, that touch you. And what I have seen there is that when patients, I put some notes on my paper because there are a lot of stuff to say, but when a patient before being intubated, they could video call their relatives, son, daughter, brother, sister, or parents, whatever they want to call. They had this opportunity. The question is why? That's because if they died, and unfortunately it happened a lot of times, if they die, their relatives, they didn't see him or her anymore except in ashes, just ashes, because they were cremated. So there was no opportunity to see their relatives again, but just ashes. They were cremated because that was the law. And if I have an opportunity to share the screen for the last time.
Yeah, go ahead.
I want to show this without talking. This is an Italian army column trucks full of coffins of people and carrying on oven for cremation because the oven in the town were full and they were unable to cremate all that bodies simultaneously at the same time. So the army took all the body of the coffins and carry on other town to other cremation oven to help to cremate all this body. And this is really bad. And also in Milan were created a camp that is called Camp 87 for all people dying during COVID pandemic with no family, with no history maybe. Thank you.
Thank you so much. Look, there are lots of questions coming in. We're going to try and answer them. But what we're going to do now is we're going to move on. Ramesh, I'd love to know about your experiences with tele-ophthalmology, with the COVID. Ramesh, thank you.
I hope you can see my slide now. Okay. I'm going to talk about the experience, what we had in the telemedicine. We used to do it, but we scaled it up because of this situation, because by not giving opportunity to the patient, we are not doing well, but we thought about it and we gave some options for the patient. I do not have any financial disclosure. COVID, what it has done and what it has changed is from patient-centric, we have become community-centric patient care. From patient-centric patient care to community-centric. While doing that, there are category A patients where there are emergencies, as Dominic said, we have to see them in the hospital, come what may. But there are category B patients where we provided them teleconsult alone, being at home during this 60 or 65 days. Even for category C patients with the intermittent teleconsults, we could provide. You can see the list in the top. We at LV Prasad, we have a team tele. It's called LVPI Connect, and this is the flow. Administrator fixes the OPD schedule, and then the patient is called, and they get the SMS link, and ophthalmology gets the same list in the electronic medical record, either sitting in the hospital or at home. We can go through all the checklist and we can take the consent from the patient. And once the checkup is done, patient's medical record is shared with them and the daily report is scheduled. How are we doing? We have to have three things. One is the Vision app. Second thing is the interface. And the last thing is the 9-Gaze app, as most of you know. It's very good. So in India, the digital connection is quite good in the last 4 or 5 years. Everybody have a cell phone. WhatsApp is much more user-friendly here. We can get almost everybody onto WhatsApp. And sometimes we use the FaceTime or Zoom or even recently Doxy.me. And these are the kids who are more knowledgeable than parents most of the times. You know, they can send this 9-Gaze pictures to us where you can see allergic conjunctivitis. And this is one of the patients with pupilloplasty. You can see the large exotropia here. And then parents showed me with the patching how he is behaving. And some of the patients, because of 60 days, the congenital cataracts have gone into the critical phase. Now, 2 or 3 months, they are into that stage. And we will discuss some of these things about the surgical cases. And this is one of the patients where they send the photograph. Patient has undergone pediatric cataract surgery. You can see one of the eye has become larger. So we could start immediately the anti-glaucoma medication. And new patients like this, where they could share all the details, including the B scan showing no lens there. And we could get fairly. And you can see the eye movements with our guidance. Parents can do that. And this is through the WhatsApp. You can see the recording, but in most of the patients we could get. And even the 9-Gaze app, we could see, and we could suggest some of the rehabilitation procedures for the patients through this tele-ophthalmology. In the last 1 month, we finalized the 161 patients with the median age of 7 years. And we used all multimedia in 70% of the patient, but 30% we could still just call them. This is because of the connectivity and other issues. And you could see the diagnosis, what you are looking at. Allergic conjunctivitis leads the list, but there are some other follow-up patients as well. And 80% of the patients who came for teleconsult, we could give them a remedy or a treatment, and close to 20% of them had to come to the clinic for some or the other reason. One of the limitation is that we cannot do the refraction for these children. That's one of the major limitation of the tele-ophthalmology. And in LV Prasad, in the future, we are going to come up with our own app called Connect Care, where everything is utilized in one interface, and we will go to continue that venture. We are venturing into having our own thing. And in all this, we have to think about health equity, how we can reach these children at far off place, remote villages. We need to really think. I think it's a fantastic platform where all of us are together. We need to take care of all of these patients. Thank you so much for patient hearing. We will have some questions a little bit later. Now I invite Ken to tell his experience about his tele-ophthalmology or digital health experience.
Good. I'm going to unmute. So I'm going to be brief. As of May the 21st, this was the confirmed COVID-19 cases per million people. The darker it is, the more there are. Remember, just because you've got areas of the world where there appears to be no affected individuals, that may be because there's no testing or the testing is limited. I think that's an important consideration. Symptoms of coronavirus, this is from the CDC for the United States. I want you to notice that the new loss of taste or smell and sore throat have become symptoms of coronavirus that we actually now ask for when we screen patients coming into the hospital. I have now got 2 cases that I've not personally seen, but I've been told about in our hospital who had Kawasaki-like disease due to COVID-19. Interestingly enough, both were negative for antibodies and negative for PCR, but the nature of the presentation has made people very concerned that it is a COVID-19 related event. So that's another whole issue. This is what we do. A lot of people asking questions. So this is for examination. If the patient is screened negative or is known to be negative, we use a procedure. The patient wears a procedural mask. I wear a procedural mask, eye protection, and gloves. If the patient is positive or suspected positive, then N95, eye protection, gloves, and a gown, and that's what we are doing. I really want to raise the profile of 2 individuals, Ofir Shmudjiak, I hope I'm saying that right, and Sigal Shmudjiak Yehiam, both from the Shamir Medical Center. They have been so kind that on the WSPOS website, they have given us for free these links, and these links take you to protective devices, and they've given for free the 3D printing files. So if you have a 3D printer, you can print what I'm showing you, the plastic bits. You have to get the plastic bit, obviously, and you can see here how this one on your right fits around your head. This is for retinoscopy. You know what children are like. They'll sneeze or cough at any time. And again, I want to thank both of these individuals for giving to the world their knowledge for free, available on WSPOS.org. All you need is a 3D printer. So let's talk about tele-ophthalmology, telemedicine. For those of you who don't know, there is something called Google Trends. If you go into Google and put trends, Google Trends allows you to search terms, and it tells you how they are being searched on Google. So the term telehealth, digital health, telemedicine, you can see that telehealth is used a lot in North America and Australia, digital health in different parts of the world, and telemedicine in India and parts of Asia. But my point is that this is data analytics that's available to you. Tele-ophthalmology really is asynchronous or synchronous. All of us, I promise you, all of us have been doing asynchronous. We get patients, parents, sending us pictures of their child's eye. We do it for retinopathy of prematurity. We do it for diabetic retinopathy. We do it for opinions from patients, from doctors. And synchronous is when either your clinic arranges an appointment for your patient virtually, or the patient has 24/7 on-demand access to a carer, not normally an ophthalmologist, in our case, a pediatrician. So the challenges of synchronous teleophthalmology is, firstly, you've got to have a basic setup. You've got to have a video platform, and Ramesh has shown you those. You've got to have consent and declaration that it's not the same as face-to-face. And the patient and the parent needs to understand that. And then you've got to have documentation to protect yourself. It's a new way of interaction. Many of you will have noticed that when I started, I was looking down like that. And I've been given expert tips by David Granite, who's a pro. And you have to look, when you're talking, look at the camera, as I'm doing now. Try and get the eye level as well. I still haven't got that. You've got to have a clinic flow. Make sure, like Ramesh showed you, you understand the clinic flow. There's a need for at-home testing. We call that peripherals, or testing at satellites that perhaps are only for testing. Patients go and get tested near to their homes, and then that information is sent to you, and you have a face-to-face. There are apps based on the smartphones. They can be web-based. There's the Strabismus app that Evan Silverstein has provided for free, 9-gaze app. Fundoscopy, there are smartphone adapters, a bit more difficult to use. I want to thank NTOD, who are hosting this. Also want to thank All Eyes, who are sponsoring this. All Eyes have a device that sits on your face like a virtual gear and allows you to do a visual field. Check it out. It's going to be very useful. It's available. On demand, these are patients who have phoned on a video visit a pediatric carer, general pediatric carer. And what we're doing is we are creating diagnosis clouds. On this diagnosis cloud, you see the symptom eye. And when you click on that, out of 290 visits to that date, 25 were because of conjunctivitis, swollen lid, or eye pain. Now, if you take this eye cloud and you now look at cough over here, you can see geographically where they are. And if the two are overlying each other, we can then target those areas and make sure this is not COVID related. The future is here. I don't think teleophthalmology is going to go away. This is a slide that my fellows, Amgad Eldi and Jamila Hayasat, put together. It suggests which visits can be primarily done by telemedicine. That's the top right. Which visits need to be done in person, and then how they might be followed up by telemedicine. We'll make that available on the website. You don't need to worry about that. So I know that was a bit of a race through, but there's a lot to discuss. I want to ask you something. Having heard that now, what type of teleophthalmology have you participated in? This is a repeat of question 3. Synchronous, asynchronous, not sure. Ramesh, take it away.
Thank you, Ken. I will show the results of Menti questions in a while as the discussion is going on. Let's have some more discussion. I have one question for Nicola before we go to Ken and other questions of teleophthalmology. A child will be always crying for ROP screening or even for laser. What do you do for crying? Any specific precautions? Because a lot of aerosols are generated there. It's same for GA surgeries as well. So any tips from Nicola as well as Dominique?
You can give them a sucrose to suck on, but most of our neonates don't have pacifiers or dummies, so that wouldn't necessarily work. There isn't much to do other than to protect yourself, to my knowledge. And I was wondering if anyone else had a better suggestion.
Some of the people use a box kind of barrier when you are doing, like an incubator. You can do a ROPs in the ICU. Any one of you use that, like an additional box where you can make a hole and go hold the lens there? Do you do, any one of you?
No, I don't do that. I think that the important thing here is that even if you wear glasses, you need wraparound eye protection or a visor. I think that's very important. I think you need a gown because if a child coughs or sneezes or cries and there's air droplets, you don't want it on the clothes that you're wearing because you know that I don't think that's a good idea. I think this is a really great question. Do you worry when you go home? Do your families worry when you go home? Max?
Well, yeah, especially my family is worried when I go home. So when I go home, I change my clothes before entering. I wash my hands, and what is important is clean the phone. This is very important. So I disinfect my phone, I wash my hands, and change my clothes before touching anyone in my family.
Anyone else?
Yes, I do the same for the family, because when you come back, you really need to be clean. And but we are both physicians, so we do both also. And for the protection also for ROP, I think we have visors, and also we have a handheld without any wire. So I think it's easier to control ROP screening for the infants.
Let me tell you what I do. I wear scrubs at work, and when I come home, I come through the garage, and we have a spray. I spray all my bag, my phone, my keys, and then I take my scrubs off and have a shower before I say hi to anyone. That's what I do. There are so many questions, so I'm going to go to the questions. Somebody's asking, does phacoemulsification cause aerosolization? Is phacosurgery aerosolizing?
Wow.
Anyone? So, I had no idea until yesterday. James Chodosh and Ed Holland on the American Academy of Ophthalmology COVID advice site have written a very nice article about this. They're suggesting that since you put viscoelastic to disperse the aqueous, that the chances are that phacoemulsification is not aerosolizing. However, I know there is a video from the Bristol Eye Hospital. One of the viewers has mentioned this, where in a cadaveric eye, they show aerosolization. The question is that balanced salt solution that you're seeing aerosolized, or is it aqueous? And then the next question is do we have any evidence? Do we have any evidence that body fluids themselves have the virus? The only study so far did not look at aqueous. It looked at semen, and there was no viral particle in semen, but we don't know that information at the moment. So I guess the chances are it's not. However, when you do a vitrectomy, the study or the paper suggests that may be aerosolizing, because you can't replace vitreous with the balanced salt solution completely. So those are important considerations. So here's another question. Do you test all your patients pre-surgery? Should you test all your patients pre-surgery?
So we do it. As I said, in France, we do it. We try to do it, because sometimes it doesn't work, because not everywhere you can have testing, and but now it's really much more easier to get the testing. But we tested all the surgery, the surgery before the day.
What about
before?
Connie, Dominique, Nicola?
Okay, we are. Should I go first, Connie? We are testing pre-surgery, but if they come in as an emergency, a corneal laceration, there isn't time, because it takes, even if you mark the test as, the PCR test as urgent, it takes 48 hours. So those patients that come in as emergencies are treated as if they are positive. And then the rest have to be tested.
Can I just clarify? When I was talking about body fluids, I was talking about intra-body fluids. Of course, the virus has been isolated in tears.
Of course.
Right? Okay. Connie?
To this day, we're not really testing our patients before surgery, whether they have COVID or not. But since we're slowly opening up our service, I don't know whether the public hospitals will actually have this as a policy. Testing is not that difficult. You can go to the private sector and get a test done for maybe less than $10 American. And even right now, I think the shift is to actually encourage more people to get tested if they have symptoms. So we're just going to keep an open mind and see how things go, because, the situation is steadily changing and policies may change.
Yeah. Can I comment? Yeah. We have started doing surgery. It's not possible to test everyone, but also with regards to testing, we can't get a positive thing from an asymptomatic carrier. So we are not doing testing, but we are taking precautions in terms of their home quarantine 14 days before coming to the surgery, and they are not from containment zone or red zone. We also take a thorough history of parents, because mother and father are closely associated. It's not only the child. I'm talking about congenital cataract patients. And also one more adjustment, what we have done is, if the patient has a high risk, we are doing more and more simultaneous, but even the surgery numbers are not so high for the simultaneous. But for the second eye, we don't do it within 3-4 days or 7 days. We wait for 14 days to do the other eye. These are the adjustments what we have done during COVID times.
So again, so many questions. I mean, amazing questions that I'm not sure we know the answers to. Now, we don't have to answer this question. 2 questions I've asked. Number 1, anybody know any pediatric ophthalmologist that has tested positive?
No.
Oh.
Yes, I do.
Yes, I do also. Right. I do.
Okay, I mean, I'm not going to say who they are, but they're well, they've recovered, and they're doing very well. 2 very good friends of mine, one in Europe, one in the United States. So yes, there are. The next question, and I'm going to ask it. I don't want an answer from anyone. I just want to show how I'm really pleased the questions asked, because they obviously feel close enough to ask us this question, right? They say, have any of us tested positive? So I can tell you I've not been tested. Nobody else
I've been tested. I've been tested on Saturday. I'm negative.
You are always negative.
Of course. You know that. I'm so sorry to be negative. I wish I could be. I'm not.
Well, this is the first time I didn't want to be positive, so I can tell you I have not been tested. So I'm not going to ask anybody else that question. You don't have to answer it. So there's a whole bunch of other questions. It says, what vision screening apps are there for younger ages? Anyone aware of any? I'm not aware of the younger ones. And even the vision apps that are present, I'm not sure they're easy to use. I think that's something we have to work on. We have to work on better vision testing applications. And if people out there, young people with any knowledge of mechanical engineering, coding, computer science, we really need you to step up and help us do this. How do we give confidence to our patients to come back? I'll tell you what we've done, but I'm interested in what you guys are doing.
I may say that they know that they will have a mask, that they know there is some special barriers. I didn't show you, but about the seats, about only one parent, and about every hygiene done. So, and we call them, all of them, that have to come back and say that it is supposed to be safe. I mean, and it is important that they come back, because they really have a disease that need to be checked.
So there are many questions, some of which have been covered by our discussion. We only have a few minutes, so I think we're going to move on a little bit. Ramesh, one of the things that I wanted to point out in the Menti questions, it was very interesting that the term asynchronous and synchronous clearly wasn't very well known, because after the talks, people very clearly knew whether they were doing asynchronous or synchronous, but this is language that we have to understand, and that's pretty impressive. Ramesh?
Thank you, Ken. I think there was one correction what is required. People are asking asymptomatic carriers will be negative for PCR. It's not that they will be negative. We can even have a false positive or false negative in this kind of patients. But with the symptom screening, we cannot pick this patient. And Ken, when you come back, you have to quickly tell what is procedural mask, because a lot of people have asked for that. For the WW attendance and participation certificates, please email to wspos@wspos.org. You will receive the certificate whenever it's ready. You will get in the next couple of weeks. And we have upcoming webinars. Our last Strabismus webinar is going to end on May 30th. The next week, next Saturday is the last one. And then we are going to go into different aspects of pediatric ophthalmology. We have a very interesting one, and Ken will give some update on that. Last but not the least, I would like to thank you, all of you, joining from all over the world, for sharing and learning and asking questions. Some of the questions we'll try to answer later, whatever is possible. And I would like to thank all the panelists for today from different countries. You all have done a wonderful job. And all eyes have sponsored today. Thank you so much for that. As always, Entod been hosting this webinar week after week. It's an excellent job they have been doing. And also, I would like to thank the admin team of WSPOS, who are doing an excellent job from week after week, talking to the speakers and arranging everything. Thank you so much. Over to you, Ken.
Okay, so here, I'm going to last minute, and I would like to share Ramesh's thank you very much to all of you guys. So we have planned, remember I said be part of history, 1st August 2020, we will make history together, but you need to get used to using the menti.com. We will give you more details coming up. I can only tell you that this has never, ever been done before. We want you to be part of this historic moment in pediatric ophthalmology and strabismus. Okay, we're going to do a survey after the last strabismus webinar at the end of May 2020. There will be a survey. If you complete the survey, you will be sent the PDFs of all the questions and answers for Duane syndrome, superior oblique palsy, and esotropia, with all the panelists' answers, and of course today's. Lots of really good questions. We'll make sure that we get them answered for you. You'll get those PDFs if you do the survey. So it's left to me to say, together, apart, all over our world, WSPOS. Remember, there's a Facebook page. Remember the international listserv run by David Granite. Email him, dgranite@ucsd.edu. Free membership for the World Society. I want to tell you something. Creativity is the dance between ideas and the means available. And what together we've done with the means available makes me proud of our human spirit and of the WSPOS. God bless. Have a fantastic rest of the week and weekend. Bye-bye.
Bye-bye. Take care, all of you.
Stay safe.
Bye-bye. Thank you.